Cool. Thank you again for joining us. I want to start off by thanking the Lupus Foundation of America, Georgia chapter again with Terry Iman and all that they do, along with the Georgia Lupus Council on Georgia Council on Lupus Education and Awareness. Sorry about that. Chris Reed and Representative Kim Schofield and the Goal Study and Emory. So just some general updates about COVID from last week, just throwing out some large round numbers. And I got a lot of these little snippets of slides from a town hall that the Emory folks at Grady do with Carlos Del Rio and some of the other specialists in infectious disease. So I'm just giving them credit for some of these slides. But the big round numbers you can see here, and the point here is that the US really accounts for a significant proportion of the cases. It's about a third of the worldwide cases, and you can see the total deaths and the number specifically in Georgia. And to put it even more in perspective, the United States population is about 4% of the world. One second here. Yet, of all the confirmed cases of COVID, the US comprises a third of all of the confirmed cases and almost a little over a quarter of the deaths. So it's a dubious honor, but we are the center of the COVID outbreak in the world, unfortunately. And then for those that, if you ever hear someone kind of mention that this is just a hyped up version of the flu, this will give you maybe some perspective on it. Over here, this blue chart is the average number of deaths per day of all causes in 2019. So that's everything put together from diseases, cancer, car accidents, and so forth, everything. And this is the number of daily deaths. Here is the average deaths per day by influenza. I mean, it's a really small slice of the total deaths that happen, as you might expect. But if you look at the average deaths per day since COVID first arrived in the US, it's still a relatively smaller slice of the overall deaths. But it's getting there. You can start seeing it, and it's certainly much, much greater than the mortality burden that influenza has. And this is an average from day one. So we didn't have many deaths in the beginning. It took some time to accumulate that. And this average is just going to go up. And you see here, this is the number of COVID-19 deaths on one day, April 26th. And so this number is going to get averaged out into all the days, like 127 or so since all of this started. But, you know, I mean, there's no question that, you know, this number over here is going to keep going up. So the point is, relative to influenza, I mean, yes, it's a similar virus, it's a respiratory virus, but it is so much more contagious. And most people do recover, but some don't. And since it's so much more contagious, that percentage of people that do poorly is going to represent a significant number. And that's what all of the efforts so far is aimed at, to try to minimize the number of really bad cases from overwhelming the hospital. So how are we doing in terms of testing? You know, one way to look at testing across different countries in an apples to apples comparison is just to look at rates, meaning how many COVID tests per 1,000 people. So it doesn't matter if you have a huge country or a small country, this is how many per 1,000. And you can see the US over here going back in February and then back up to May 1st. And the test number is rising dramatically, which is great. But to give you a little perspective, a smaller country like Italy, they're testing a lot more people per 100,000 than the United States. So we need a lot more to go. And we mentioned this in the past, and we're trying really hard to get there. And that's going to make a big difference is if people can get rapid testing quickly and cheaply, then we would be able to have peace of mind, number one, but also to identify people who are infected, especially those that are not showing symptoms. And we can isolate them and try to remove them from the general population, at least temporarily, kind of what we're doing now without knowing who is infected and who isn't. We're just doing general social isolation. And we had that stay-at-home order to get the entire population at home for a while. So these are the states that are reopening, and the ones in green are fully under a partial reopening. And you can see Georgia is a part of that, and you see the belt coming across here, and then Minnesota and Montana. And then the light green are the ones that are going to be lifting some partial orders like Georgia pretty soon. And the ones in orange here are the ones that are still fairly restricted. And again, I can't take credit for this analogy, but from a public health perspective, this really doesn't make sense. It's kind of like peeing in a pool. You can't just sort of have somebody pee in the corner of the pool and expect it to just kind of stay there, right? So the fact that there's so much lack of coordination across the country, and with this occurring from an epidemiology or an infectious disease standpoint, it really is not the most efficient way of doing things. Well, we know that Governor Kemp, and he lifted the shelter-at-home order as of late last week, and this is a quote for him. He said, "I felt like the negative effects of not having our economy starting to open up was beginning to have the same weight as the virus itself, especially if you weren't in the medically fragile category or someone in a long-term care facility. For most of the rest of Georgia, the effect has been minimal." And, whether you agree with it or not, that's the reality of his perspective. And it's translated into where we are now. And we'll just hope and pray that he's made the proper decision. And we won't really know until about maybe 2 weeks from now. But this is kind of how he based it on are figures like this. And this comes from the Georgia Department of Public Health website. And it shows that the cases are starting to come down and the deaths are starting to kind of level off and come down too. And you may have seen in an AJC report, basically, there's a question of where these numbers have, came from, and there's not a full explanation of it. And so there's a bit of controversy there, but regardless, the reality is I don't think there's going to be any turning back at this point in terms of a governor's decision. And this is sort of the backdrop of that. I think just to balance that perspective, if you look at the states that are reopening or have reopened, Georgia has the most number of cases and deaths. And it's really only second in terms of Georgia has the most number of cases and the most number of deaths in terms of the states that are partially reopened. And it's really number 2 to Colorado in terms of the cases of COVID per 100,000 people. So, I mean, we're up there in all 3 categories. So we're going to have to be, careful in the coming weeks, and we'll see how this translates. This is the Institute of Health Metrics and Evaluation projections. They're just one of many independent organizations, and these projections are tricky, I have to admit. It really depends a lot on the assumptions that you make and a lot of fancy statistics. And models differ according to how people put in that data. So there's a lot of variability somewhat, but for what it's worth, this one is one of the more quoted projections that are out there, and making sense of what they project. They had projected that we've already passed our peak in terms of this past surge that we were expecting. And the good news out of all of this, again, what underscored Governor Kemp's decision in part is the fact that, if the surge did truly come, it didn't leave us where we were in a situation like those scenes out of Italy where they just didn't have any beds and intensive care beds and ventilators. So we were fortunate in the sense that we didn't get to that, although we had plenty of carnage. I mean, there was just a lot of people affected, still a lot of deaths in certain areas. And their projection, given this, would have suggested that relaxing some of the social distancing measures and opening things up partially would have been better done a bit later, like after June 27th. And so, really ultimately what it comes down to is the hope that this premature removal of social distancing, it's not that social distancing goes away. I mean, the recommendation is still everybody should be wearing masks, they should still social distance. But the other reality is that if you start opening up or partially opening up certain businesses where you just can't help but have people in closer proximity, and there are certain people that are going to be more careful than others, there's going to be more transmission. And so when you remove some of these restrictions and you allow people to mingle more on a large level, and you do it earlier than the models suggest, then what we're concerned about is that you're going to see a rapid increase in the case of emergencies, and the deaths that were starting to level off and go down will start picking up again. But again, we'll just hope and pray that he made the right decision, and we should all be in prayer for that. And we'll see over the next couple of weeks. In terms of the total number of cases in Georgia, as you might expect, given that there's so much more population in the Atlanta area, you're going to see a lot more. The red numbers are the higher number of cases, and then as you get to lighter shades of blue, they're fewer and fewer. But keep in mind, these other areas that are in the rural counties, there's relatively fewer populations, so that even a smaller number kind of means a big impact. In other words, 2 cases may not be a big deal to you, but if there's only 4 people in the county, that's half. So that's a bigger deal for them. And again, to put this into perspective, if you look at the number of cases per 100,000 people in the most impacted counties across the US, Georgia has a distinction of having 8 counties in this top 50 list you see circled. You see Randolph, Early, Terrell, Doherty, Calhoun, Mitchell, Sumter, and Lee. And these are rural counties, and so they're much more disproportionately afflicted. And just to underscore that even more, I think the easiest thing is to look at the right side here. These are the rates again. So you can compare apples to apples. It doesn't matter like how big or small the county is. This is how many per X number of people are afflicted with COVID. And you can see up here, you see areas like South Fulton, Atlanta, Hapeville, East Point, College Park. And then at the bottom, you see Alpharetta, Johns Creek, Roswell. And so what's really coming out here is this socioeconomic disparity as well. And that plays out in the rural counties, but also in Atlanta. You're seeing a disproportionate burden of COVID in the southern areas as opposed to some of the northern suburbs. And that's something we need to keep an eye on. In addition to the racial disparities, more in African Americans. And I think, again, it points out to some of the areas as well. The MMWR is a morbidity and mortality weekly report. It's a weekly online scientific journal, if you will. published by the CDC, and it's really highly read, impactful scientific journal. They do try to make it worded for a lay audience. You don't have to be too scientifically trained, but they do a very solid job in terms of presenting science. And so the hottest topics they'll present, and it gets a lot of press. And this is the MMWR report that came out not too long ago, April 29th. And it talks about characteristics and clinical outcomes of adults who are hospitalized with COVID in Georgia. And the take-home points from that report is that, especially in Georgia, it's disproportionately, this virus continues to really disproportionately afflict Black communities. And, I guess one thing also to kind of mention to your friends and family is that, we're hearing a lot about people who get severe infections or severe complications from the infection, having comorbid conditions, meaning other medical conditions that really put them at high risk for that. We're hearing about diabetes, obesity, high blood pressure, heart disease, lung conditions, and of course, being immunosuppressed. But what also came out here was that 1 in 4 patients, which is not a lot, but it's not a little either, 1 in 4 who were hospitalized with severe disease did not have any one of those high-risk conditions. And so we all need to be careful. And I think that's the other take-home message too. And then the fact that this virus disproportionately afflicts certain racial groups, we need to investigate the role of socioeconomic and other structural factors in driving these racial disparities and socioeconomic disparities that we're seeing in the virus. Okay, I'm going to transition to questions now, I think, yeah. This is from a concerned nurse mom, and really, you can read the details here, but it's talking about just this tremendous story of her daughter and how she's been through so much, and she's getting rituximab, already a lot of doses compared to most. And the mother is a working registered nurse, and she's terrified for the daughter in the midst of all of what's going on. And she asks about recommendations for keeping her daughter well with lupus during her treatment, especially this immunotherapy with rituximab, and how does it translate for the caretaker, her, who's on the front line. And we can translate this in a lot of ways too, to a lot of other people similar to this, in the sense that we have a lot of our members, our friends, our family members who live with lupus, who have been really exposed to a lot of immunosuppressive medications that have very active, severe lupus. And then many are being taken care of or live in the same home with people who are frontline providers. And the frontline providers are certainly medical, but they are also definitely the ones that are working in the grocery stores, that are getting the supplies that we need for daily life, the teachers. So we can put a lot of people in the frontline bucket, and you all know who you are. And so as we go into this phase, what do we do? And I think one way to look at it is to try to be as rational with the fear as you can. And, I think a certain amount of fear is understandable, it's expected, and one can even say it's healthy, because you don't want to be too complacent during this period, obviously. And there are some who are, and that's our coping mechanism, and we need to be careful of that. But just like everything else, fear taken to an extreme, that's really not supported by rational arguments, that has the danger of being harmful, because it's unfounded. And what I keep reminding people is that you could be the most immune suppressed person in the world. You could double and triple all of these medications. It it really won't do anything for the COVID virus. Is not going to infect you any easier if you practice the safety techniques and the distancing um, that you need to be doing to the best of your ability. Uh, Meaning that yes, there's always going to be a risk, because even if you do practice all these things perfectly, there's always a smaller chance that something can go wrong. You make a mistake, or you just didn't wash well, or something happened. But those chances are relatively small, and I'll go into this in a little bit later. But um, the risk of developing the virus really just depends on all the measures that we've been talking about day in, day out, week in, week out, and that is the social distancing, the masks, the um, hand sanitizing, the not touching your face, and not being around people who have been exposed directly anyway, or who are suspicious of having the symptoms of COVID. And even with the social distancing and all of that kind of being downgraded a bit, and the state opening up partially, it doesn't change any of this. If you just practice these things, even if you're the most immune suppressed person in the world, or walk around with really severe lupus or lupus of any kind, it doesn't mean you're a magnet. It doesn't mean that the virus will go through masks easier to get to you because you're immune suppressed. Once you have the virus, once you get infected, God forbid, then that's a different story. And I think the fact that you may be very immune suppressed, the concern is that you may have more complications. It's not a definitive thing, but that's a concern if you get exposed to the virus. And so, I think for all of us who know somebody with lupus that have been on any of these medications, that have the concern, it just reminds us that this is a marathon. You have to be as vigilant each and every day. And I know mentally and physically, it probably is starting to become a drain for some people to be constantly thinking about this when they go outside, constantly on guard, constantly washing their hands. But that's what it takes. And I think on one hand, it's a bummer to do that. And it maybe underscores a lot of the fear, because you're having to do all of this, and it really reminds you of your susceptibility every day. But if you do it each and every day very well, then your chances of acquiring the virus become very, very low. And it's been shown that, especially as it becomes more commonplace for people to wear masks, and I'm still seeing a lot of people that aren't, but the people who are wearing masks out in public have gone up a lot, at least where I've interacted, and hopefully in your area. But as that becomes more ingrained into our just everyday routine, that and being safe with our hygiene, that will protect people. And there's a lot to be said by that. And in some cases, there was a lot of risk even before all of this, when people were walking around not being vaccinated for the flu, and people were sick all around them. And there are a lot of, maybe some of you who are out there now, and who were like that before. And that was without any sort of risk of minimizing behavior, no mask, and people weren't sanitizing themselves as much now. But now people are really focused on that. And I think as long as there isn't a breakdown in that each and every day, people, I think, should expect to be fairly well protected. And I think if you're a frontline provider in whatever field that you are, and you have to come home to somebody who's immune suppressed, Again, this is a big if, but if you are able to maintain all of these practices at work, you try to minimize direct contact, you're working with your employer, that's where we need to get to, so that when you do get home, you're able to uh, clean your hands, change your clothes, and you should have minimal risk in transmitting it to other people in your home, as long as you've been safe on the outside. And this is going to be a reality going forward. I heard there will be a vaccine by September. Oh, I'm sorry. I just went over to look at some of the questions. My point is not to really minimize the fact that people are with lupus and are on these medications are going to be at high risk, and that's the key thing. So I think that's important to be reminded of that. But I think what I mentioned before in that slide before, 1 out of 4 people that are severely sick, hospitalized in the ICU, don't have any risk factors, including lupus or immunosuppression. I think all of us just need to practice the social distancing and the healthy measures. And if we can all do that together, we can really minimize some of the risks that we have. And yes, many people with lupus are at higher risk. But I think everybody is at sort of similar risks, in that if you do get it, there's a chance that things can be severe, and we just need to be careful together. The vaccine by September is a very, very accelerated time frame. It's a possibility, but there are a lot of caveats. I think it's a vaccine group in Oxford, in London, England, that is probably the furthest along, that may be reported to be one of the earlier ones. But in any case, there is a group that thinks that they might be able to have a vaccine by September. Now, that means that everything goes perfectly from now until September. And even if it does go perfectly between now and September, I think it takes several more months after that to ramp up the production and to have it go out into the public and available. And that's really when people truly know the effectiveness of a vaccine. You can get early results in the clinical trials, especially about safety, obviously a lot about effectiveness, but the true effectiveness and the true safety won't really be known. Well, will be known much better when it is mass produced and out into the public. And that'll be several months after that. So if this question is, if the thinking behind this question is, well, after September, like meaning this fall, is there a chance that the general public, you can get access to a vaccine that's effective and safe, and maybe we don't have to walk around with these masks and be somewhat closer to normal like we were before the pandemic? It would be highly unlikely. But the fact that we're even talking about a vaccine getting to that early phase in September is extremely unheard of before. And so that tells you how quickly people are moving through a process that is so complicated to begin with, and they're moving at light speed. So that's only one, and that's a big if that it even gets there. So I think if you're more conservative, you're probably thinking much more later down the road, like maybe 6 to 9 months conservatively after that, when several other vaccines will probably be at that point. And hopefully at least one of those out of that group will be effective enough to be worthy of distributing out to the public. So we talked about the Plaquenil a lot in the past, and so we're not hearing much more about Plaquenil in the press, and this was somewhat of, not a concern, but a possibility that I had mentioned earlier, in that if we don't start seeing a lot of positive early results from some of the clinical trials with Plaquenil, and or there are some positive results from other drugs, then we're going to get the situation where Plaquenil was yesterday's news. And it's not quite yesterday's news, but it suffered from some additional early studies that haven't been as positive. The studies, many studies are still going on. The ones that really do count, if you will, that are much better done than the ones that have been reported. But that's going to be probably a good couple of months or so out before we start hearing some early results from those studies. In the meantime, we're hearing from other drugs, which we'll talk about in a second. But in the haste of the government, and especially with the encouragement of the president, just getting out and stockpiling Plaquenil into the federal stockpile has happened, and there are millions of doses that have been donated by the companies to the government. I haven't heard anything about how that is going to be used at this point, and we probably won't know for a while, because they're probably going to wait until some of these other studies come into play. And if they very well, there could be some studies down the road that do show effectiveness, and then Plaquenil gets back on the radar. And so the stockpile is really there to protect the use of Plaquenil for the sickest people in the hospital. And so it's not going to find its way to the general distribution, especially people that are with lupus and rheumatoid arthritis that are taking it as an outpatient. I don't even know what the process is for something to go from a federal stockpile to the general public. I have a feeling that it just goes in the stockpile, and it probably will stay there for an indefinite period of time, until the government is absolutely sure that it does not have a use for it. I mean, hopefully it determines it has a use for it, and they'll distribute it accordingly. But let's say 4 years passes or so, and the government sees all the results and they're, God forbid, all completely negative, then how does those stockpiled drugs go back into the general circulation? I don't think we've ever been in that situation before, because they've had to stockpile a lot of supplies and things like that could potentially be used in the future for like wars and catastrophes. Equipment, health equipment, ventilators, things like that. But with a medication like Plaquenil that's really only been indicated for lupus, rheumatoid arthritis, and malaria, what the government would do with that if there are no studies to show its effectiveness in COVID is uncertain. But the bigger question, really, I think 30 million doses sound like a lot, but given how many doses are used in a year on an outpatient level, it's not going to be a long-term solution. And we're really going to go back to the point where there are only a few companies in the world that are making this, and maybe not in the US, long-term anyway. And we may get back to the point down the road where Plaquenil is not as available as it should be in general. And we were all through this before the pandemic. So hopefully, we got into some of the politicians' ears. We were getting into the policymakers' consciousness. They certainly know about lupus now and Plaquenil, and as we go back to them in the future to make sure that lupus patients get access to medication, that we would be able to get more support for that. Not just for Plaquenil, but for all the medications that you all in our community really need access to. Remdesivir is the drug that is really getting the news these days. It's produced by a company called Gilead. It was originally developed for the other SARS virus several years ago, and it works on a similar mechanism that might work in COVID. And The news that came out really, I mean, the NIH sponsored this trial. Emory is advertising a lot because I think they were the biggest recruiter of patients into this study. It's called the ACT trial. And what you're hearing really is at the bottom here, it's the time for recovery for those that, I mean, these are really sick people, keep in mind, in the hospital and the ICUs. Those that were on remdesivir, sort of the middle time that it took for them to get to recovery was 11 days on remdesivir versus 15 days for those who are on placebo or nothing. And so on one hand, that's a 31% faster time to recovery, and it was statistically significant. And that's really what caught people's attention. But some of you may be saying, well, you know, it's not a cure, and it isn't. And you're going from 15 days to 11 days. It may, on the surface, for some of you, may not seem like a big deal, but it may be. And the fact that it's statistically significant, the fact that you have in one group a clear lowering of the time, a decrease in the time, in a virus, an infection that has no known treatment, I mean, that is something to get excited about. And then in terms of the death rate, we're talking about 8% of the group on remdesivir unfortunately passed away, but that was compared to 11.6% in the placebo group. And it was not quite statistically significant. This p-value, if it's less than 0.05, is when we think that the difference may be not something that's just out of chance, but it's close to 0.05. It's not quite. But the thing to remember here is that this is very, very early data that normally would not have been leaked out like this, if you will. There's a group called the Data Safety Monitoring Board, or DSMB, part of all clinical trials. They're an independent group, and I've served on some of these for other clinical trials on lupus. We have no tie to the study, and when you serve on these boards, and they have different expertise in that board, and they look at data from the study at different points. The first thing is to look for safety. And if you remember that Brazilian study of Plaquenil, where they stopped it early because there were more deaths in the group that were getting chloroquine and azithromycin and getting these heart arrhythmias and dying early. That's the purpose of this DSMB, is to be an independent group that sees those signals. And if you're a company that has millions or billions of dollars at stake, you may not be as eager to stop something that you've invested, or you may just not know. But that's what a DSMB does, and they saw a very early cut of the data on April 27th, and this is what came out of it. So this is extremely early, but it's potentially exciting, and I think especially since no other study up until this point has had this level of positivity, if you will, even though it's early, it is something to be optimistic about, but it's far from secure. And it can go either way. This could be just such an early result that later on, more of the data becomes less exciting. Or the other possibility is that as more data comes in, it could even show even a stronger and more positive result. So it may be more of a home run than people are getting excited about. And the thing is, you just can't know by looking at the numbers right now. All you can say is that it's encouraging, if anything, and it's much better than seeing no difference at this early stage. But again, it's still early, and they are going to get more and more data coming in over the next several more weeks. And just like everything we've been talking about, it just takes a little bit more time. Everybody's eager, but I think in the next 2-3 months is where we're going to start seeing a big spike in the information that comes out. So remdesivir is not the holy grail, but it is exciting, and we'll see. And there are a lot of other studies in remdesivir other than the NIH study, which is here, but there's a couple big ones in China. There's a couple by the company itself. And then there's an NIH study that's combining remdesivir with a drug that they use in rheumatoid arthritis called baricitinib, and combining the two. So we'll see. And there are many, many other studies going on, and we'll see. So should people with lupus still wear masks and social distance? And how about plane travel? And so kind of talking about before, the only thing that's changed is a government decision recently in some states to open up some businesses. Nothing's changed about the virus. The virus is still around. It's going to be around. It's still highly infectious, and we need to practice all the measures that we've been talking about today and you've been hearing about. So I don't want you to get the impression that anything is really changed. They're opening things up because they've made a decision, as I mentioned earlier, that is political and economic. And I'm not saying that those are not considerations either, but it's a tough decision between how many people should we expect to increase in terms of infections that's acceptable versus how much economic activity are we willing to suppress, and the people whose lives and livelihoods are dependent on that. And so the decisions that are occurring now, the beaches that are opening up, the stores that are opening up, it's a political and a business decision. And in terms of we as individuals, nothing's changed in terms of the virus and its risk to us, and the fact that it's out there, and it may be even more out there as people sort of intermingle, and many of us expected transmission to go up. So it's highly, highly important that everyone with lupus and the caretakers of those with lupus continue to practice these safety measures, wearing a mask, social distancing, and to be out in the public with those secure measures. On that end, before I close, and maybe I'll just look at a couple questions that are coming in, but as the businesses open up, the hospitals and the doctor's offices are starting to discuss plans to partially open up as well. And I just threw this out for you all to start thinking about this, and you can talk about this more over the next few weeks. I mean, this is in part a political and economic decision as well. I mean, there's no, I mean, it's very clear that doctors and hospitals, doctors' offices and hospitals are businesses too, and they're really hurting in terms of the economics. But at the same time, I mean, they know as well as anyone about the risks. And so it'll be interesting to see how this sort of translates and how much telemedicine occurs. And maybe it would be good to maybe have one of these weekends where we have more of a discussion about that in detail. But I do know that Grady and Emory, I mean, what I know best, they are starting to talk plans, at least in a couple weeks from now, and having a very limited number, it's a small number, of those that are really the sickest and the ones that desperately need to be physically seen, even given the risks, having the some parts of the clinic open up for physical visits, but still be predominantly telemedicine. And then we'll have to see over the next couple of months or so as to how things are happening in the community, as to how these systems open up in general. But at the same time, it doesn't matter what the systems say. What does it mean to you? Just because a hospital system or a doctor's office says we're open for business, and we have all of these slots and you can physically come in, doesn't automatically mean that you do. And how does one decide? And will telemedicine be around as an option for those that want to continue to that to some degree? These are all great questions that some of you have already asked to some extent, and I know that you're asking now. And I'm just kind of verbalizing them to say that I acknowledge them, but we don't have clear answers yet. But this is becoming, just like all the businesses that are opening, the healthcare system is going to open up again soon too, and we need to discuss that as a community. So would love to hear back from you with regards to more questions along that end, as well as your observations, because I need more eyes and ears out in the community, and it would be great to hear what your experiences are along these lines. So as you continue to go to the Lupus Foundation of America Georgia website, lupusga.org, keep going to the COVID resource page here, and also keep sending your questions and responses to my comments to info@lfaga.org. If you can let me know what's going on in your world, your experience with your doctors, it would help me kind of put into perspective and maybe tailor some of my responses. Okay, I'm just looking at some of the chat stuff. What can we do regarding the underserved communities? And I'm still trying to set, we need more information, number one, and data, and just like everything else. And there are a lot of people that are starting to do this. It's on a lot of people's radar, and it's an important issue. And I'll tell you myself personally, this has been my life's primary mission, is to better understand and try to reduce the racial disparities that we see in lupus. So I just know that we're really working towards that end, and we'll have more to talk to you about that. Vitamin D is something that has been talked about with the immune system for a long period of time, and I don't think there's any role for that in COVID, to tell you the truth. I'm not aware of it being measured per se in the people that are infected, but I can guarantee you it'll be low, because people that are sick aren't going to go outside, and that's a big reason why people have low vitamin D, is they don't go out into the sun. And that's the same reason why a lot of people with lupus have low vitamin D, because you're taught that you're photosensitive, and that may trigger lupus in many people with lupus. So I'm not really sure if that's going to be a solution. Thank you for kind words. Yes, the businesses are opening, but just remember, the virus has no idea that businesses are opening. It has no idea about anything. I mean, nothing has changed fundamentally about the virus. This is all a political and economic decision. So with that, I want you to remember that when you start walking outside, and just remember the early days at the stay-at-home, and we were all scared to death and to touch everything. I don't want you to be that scared. I mean, we're a lot more knowledgeable now, but I want you to remember how concerned you were and how careful you were. And it shouldn't change one bit now. You should be as careful with everything that you touch in terms of and your safety, by protecting yourself, demanding that the people around you practice it as well in terms of the mask, because if they know that you're immune compromised, to them to be sort of frivolous and not wear a mask, that's really an assault on you and your health. And so you really need to educate people in an edifying way, of course, but we need to really get that out there. And Terry, you mentioned about managing telemedicine seminar on Thursday night. I didn't know about that. That's great. Try to get on that. Please complete the survey link in the chat box that Terry, and it's also on the website, I think. We want your feedback and how we can do this differently. False negative results. Is it worth even getting a COVID test? Um, there are a few different tests out there, and they vary in terms of how well they do. And yes, there is no 100% perfect test. So each test, and this holds for every test, not just COVID tests. Every test has some percentage of false positives and false negatives. But these are going to be very generally small. And are there going to be examples out there that someone got a test and it was a negative test when they really had a virus? Yes. But that shouldn't keep you from doing these tests that are out there. They're out there because they've passed a certain bar. And the reality is they're going to catch most of the cases. And so at some point when the tests are out there, and you have the ability to check, I would recommend getting checked, because there are a certain percentage of people that are asymptomatic, and you may be walking around, and if you're a caretaker of somebody with lupus that's immune suppressed, you're putting their lives potentially at risk if you're an asymptomatic carrier. And if what I've been taught is that it's clinical suspicion, just like lupus. That clinical suspicion should drive your decision making. Meaning, if you had somebody who's known COVID cough in your face, and you got a test and it showed that it was negative, but you're feeling kind of funky, you should assume that you have COVID. It doesn't matter what the tests say, and you should get tested maybe 2 or 3 times because you have such a high suspicion. And so it's really that suspicion that also should be a part of your interpretation of the test. If you do get a test for anything, by the way, and you really feel that it could be something that the test missed, it's always worth getting it, double checked, and sometimes even triple checked. But by the time you double or triple check it and it remains consistent, then the chances become even much smaller that really is a false positive or a false negative. The telemedicine in the future is not, it's not completely clear. Let me take this back. What is clear is that the telemedicine rules as they are now will change. And some of it will go back to the old way, where it would make it less attractive or more difficult to do telemedicine for practices. But some may stay, and some may go away and come back. So I think some healthcare systems and some doctors are assuming that the rules will change so that it doesn't make it easy for them or financially feasible to do telemedicine in the future. And their suspicion to some degree may be correct, because, like I said, some of these rules will go back to where they were before. It was an emergency exception, if you will, given the extreme circumstances of COVID, that they really made it easy to do telemedicine. So it is going to go back to some degree. But on the other hand, what is clear is that it's given us in general a lot of experience with telemedicine, and it's really brought us light years ahead of where we were before. So we know a lot more of what it can and can't do. And so I think it's definitely going to go back to some degree, but maybe not completely. And it may be to the point where it is feasible for a lot of doctors and health systems to do telemedicine in the future to some degree. It may not look exactly to the full extent of what we're having now. How different it'll look, I don't know. Maybe better, maybe worse, I don't know. But I think it's way too early to say that people are not going to do telemedicine. I can tell you that, and I mentioned this before, at Grady, and Grady is different, but it's very similar. I mean, it's got the same issues of finances as a lot of other health systems. I know it's slightly different in some regards, but the principles are still the same. And I can tell you that Grady is all in, and they see a future for at least a portion of the clinic to be telemedicine. And I think that's the right answer, is that how can you just go back to something like it was before? I mean, clearly telemedicine has some advantages in some situations. And so it's got to be somewhere in the middle that we land, but we don't know where it's going to be. Cold weather not affecting COVID, we don't know. The suspicion is that it may, or hot weather or seasons, how does it affect COVID? And we talked about this in the past. We just don't know yet. We don't have enough time. We need a good full season, and maybe in a couple of different environments to really know how this how the hot or the cold affects the virus. And so I think the messaging that's going out there in terms of the press, my take on it is to really dampen expectations so that people just don't automatically assume it's summertime now, we can go to the beach. And they're so used to thinking about the flu in terms of a winter disease that it's way too early to think that way. And all it does is get people to become overconfident. And when we, at a time that we can't afford that to happen. So I agree with the message that we just don't know. Summers may make an impact on that, but the point is, we just don't know. And I'd much rather us say after the fact in the wintertime, looking back and saying, yeah, the summer did make a big difference, and go to the next summer more confident, maybe in a way that things will get better. But it would be a big mistake for us to be overconfident. When we're at the pools, it'll be interesting to see when the pools open up and things like that, how to do social distancing there. Because if the virus isn't affected so much by the heat, then we're in for a rude awakening. We're going to have huge numbers going into the winter when we know for sure, along with the regular flu virus, that cases will go up, and so it's going to be tricky. So a lot of things to learn over the next several months, but a lot of hope too. And I hope that you take out of all of this that there's a lot of things going on in the world that really point to the smartest and the most dedicated people. And this is just not at the scientific end or the the doctor end, but we're talking about people that are in business and really in the day-to-day, like how to run a business while doing anything, distributing, wholesale, fast food. I mean, I think people become really creative in becoming very productive in a new environment and adjusting to this new normal. So, and I think that's what you all, as people with lupus, will do. And I think the reality is setting in, hopefully for most people, that this is not something that's going to go away now, even with opening up of businesses. But that doesn't mean life stops. It just means that you're already trained to be super careful to begin with. Probably better, better than most is my argument. The good news is that even though people with lupus do get COVID, my strong sense, and again, this is not based on any solid data yet, but we are going to start getting some more studies soon, is that yes, people with lupus get COVID, but I am not hearing from anybody in the United States or in other countries where we're seeing a huge spike in cases with people with lupus or rheumatoid arthritis, or those that are on immune suppressing medications like what we have. And it doesn't mean that you're not at higher risk for getting infections or the complications. This is just my personal suspicion. I just think that you all are just so much more attuned to this issue than the general public, that in some ways you're already used to sheltering because you've had to shelter in many regards. And you all are going to be teaching us moving forward how to live life, and that you will be doing, and you have been doing that, and you've been a tremendous source of encouragement for me. And in some of the darker days of the early COVID for me, I've went through my struggles and anxiety too. I shared some of that earlier, but several of you, just seeing everything, it reminds me of everything that you have been dealing with even before the pandemic. That's just made you even more resilient and more equipped to go through this. So I think you all need to be really up there in terms of the frontline providers, and you provide a lot of source of inspiration for me. Okay, I've talked way too much like I normally do, but it was great talking to you guys, and have a great weekend. And please keep emailing info@lfaga.org and give us your insight in the survey. Have a good week, everyone.